policymakers, promote testing policy changes, promote funding priority changes, and to change funding priorities. Just summing up here now, advocacy-related activities address decision makers and policymakers, promote testing policy changes, promote funding priority changes. Then capacity building activities include training staff, training health professionals, educating medical students, and training volunteers. And then finally, doing new testing activities to try out new innovative testing activities, approaches to offer testing for more infections than we normally offer, to offer different types of tests we normally offer, and to reach different target groups. ETW has become a network of networks, big reach and impact, increased focus on testing at the country level in the context of a European-wide campaign, improved sharing of lessons learned across borders, reaching new groups at risk, which is very important today, more access to self-testing, which is a new form of testing that's being expanded, and more focus on integrated testing. These are the highlights for Spring ETW 2023. As usual, a number of activities are organized centrally for each testing week. This includes promotion of the European Test Finder, which is a website where people can search for the nearest place to get tested for HIV, hepatitis, and STIs. Our statement for this testing week emphasizes the importance of strengthening collaboration between networks and organizations across the disease areas and key populations who have a common interest in uniting to promote testing for HIV, viral hepatitis, and STIs. And then we have organized a webinar with ECDC, from which Anastasia comes, that will take place this Wednesday and feature a number of European experts. You can take a picture of this if you'd like. This is pictures of activities from ETW, including the website, including the email address and the campaigns. And finally, I want to thank everyone who's contributed to this, the working group, including EATG, which is the Policy Secretariat of Eurotest, and not least of all, 700 plus organizations across Europe who organize activities to support Testing Week. Thank you very much.
Thank you very much, Ben. It's really amazing what the European Testing Week has arranged and has accomplished so much so far. We'll continue with the next speaker, which is Laura Fernandez Lopez from COBATEST network, and she's going to speak about the impact of European Testing Week on testing in community settings across Europe.
Yeah. Okay, I will try to share. Okay, can you see the presentation, the slides? Can you hear me well?
Fine.
Okay. So, as I said, I will try to show you the impact of European Testing Week on testing in community settings across Europe using the data from the COBATEST network. Okay, so according to the evaluation report of last spring and November European Testing Weeks, most of the organizations that sign up were organizations that perform testing on a regularly basis. And as also Ben mentioned before, most of them were community-based organizations. Several meta-analyses and systematic reviews have demonstrated the effectiveness of the screening strategies in the community setting, as those community-based and community-led testing services can reach effectively key populations and vulnerable groups, especially those harder to reach. The COBATEST network is an European network of community-based voluntary counseling and testing services, what we call COBATEST, that share harmonized testing data. The network is coordinated by EDAction Europe and CISCAT, and CISCAT is the responsible of the monitoring and evaluation of the testing data collected in the network. Currently, the network is formed by 110 centers in 27 European and 2 Central Asian countries. The objectives of the COBATEST network were to promote and to increase visibility of community health work, to advocate for the inclusion of community-based testing in international policies and national plans across Europe, to generate, analyze, and disseminate harmonized community-based testing data that can be used at local, national, and regional level, to strive to be representative of the reality of community-based testing in the WHO European region, to increase the quality of those services in the region, and to promote synergies and alliances with other stakeholders working with key populations. The members of the network have different ways to share their testing data with the network. They can use the free online data collection tools that COBATEST network offers. For those already using their own data collection tools, they can submit disaggregated data according to some specifications and requirements. And for those already using their own tools and with the capacity of analyzing their data, they can submit aggregated data with the indicators already calculated. So we asked ourselves if the data collected routinely in the COBATEST network could show the possible increase in the number of tests carried out during the different campaigns of the European Testing Week. To try to answer this question, we made time series representations of the HIV, hepatitis C, and syphilis testing data collected at the COBATEST network database, and made comparisons of the testing volumes and the percentages of change during and after the different European testing weeks compared with the pre-testing week baseline. For this analysis, we have only used the data from those members of the network that were using the COBATEST online data collection tool for reporting. So in this slide, we can see the time series representation of the HIV tests performed per week by the COBATEST network members using the COBATEST online data collection tool in the period 2014-2022. The vertical red lines indicate when the different European Testing Week campaigns took place. And in the circles, we can see the percentage of change in the volume of tests performed during each European Testing Week compared to the week before. In green, we can see the increases, and in red, the decreases. We can see that the percentages of change have been varying in each European Testing Week, although the most relevant increases were those of the November 2019 pre-COVID year, with an increase of 118%, November 2021, the first year after the COVID lockdowns, with an increase of 379%, and November 2022, with an increase of 259%. 2022 is also the year where the impact of the Spring European Testing Week was higher, with an 86% of increase. In this slide, we can see the same time series representation, but for syphilis tests performed. We can see that the number of tests were lower than for HIV, and that the main increases took place in the November European Testing Week in 2021, with an increase of 224%, and in 2022, with an increase of 218%. The higher increase in the volume of tests performed in the Spring European Testing Week was in 2022, with an increase of 56%. Here we can see the time series representation for hepatitis C tests. The volume of tests were smaller than for HIV and syphilis, although in 2021 and 2022 European Testing Weeks, there was also a big increase in the number of tests carried out, with 129% in the 2021 November European Testing Week, 81% in the 2022 Spring European Testing Week, and 326% in the 2022 November European Testing Week. This slide shows the time series representation of the tests carried out for the three infections together, with the different European Testing Weeks indicated with the vertical yellow line. We can see how in the last years, especially in 2021 November European Testing Week and in both 2022 European Testing Weeks, there was an important increase in the number of not only HIV tests, but also in the numbers of syphilis and hepatitis C tests, indicating, as Ben mentioned before, the integrated testing sessions for the different infections have increased. We can observe this more clearly in this other slide, where the time series representation is for a shorter period, from 2018 to 2022. And we can see how the peaks of increase in the last European Testing Weeks are for the three tests at the same time, especially in the 2022 November European Testing Week. So we can conclude that testing data from the COBATEST network confirm the impact of the different European testing weeks on testing uptake. This impact on testing uptake is especially high in the last November 2022 European testing week. In the last European testing week, we can observe the increase of integrated testing for HIV, syphilis, and hepatitis C. And finally, that the routine collected testing data from the COBATEST network can be used as a proxy for evaluating the impact of European testing week campaigns on testing uptake in community-based voluntary counseling and testing services across Europe. And that's it. Thank you for your attention.
Thank you very much about this presentation. Actually, it's very important that besides HIV, testing was increased also for hepatitis C and sexually transmitted infections. Very interesting results. Thank you very much. We'll continue with the next presenter. It's Esteban Martinez, who's the president of EACS, of European AIDS and Clinical Society. And the title of the presentation is the importance of early testing from a clinical perspective.
Δημήτρη, αν δεν είναι, να πάμε στον επόμενο speaker και τον πούμε.
Since Esteban is not online, we can continue with the next speaker, who is Tahinder Tiwana from the World Hepatitis Alliance, and is going to present what needs to be addressed to close the testing gaps for hepatitis. So we will be hepatitis.
Hi, thank you. I just firstly wanted to say thank you for having World Hepatitis Alliance be a part of this event and initiative. So at the Alliance, we are an international network of organisations working in over 100 countries towards the goal of eliminating hepatitis by 2030. Our networks comprise civil society, community organisations across the world, and together we're leading the fight against hepatitis through advocacy, capacity building and awareness training. As mentioned, I'm speaking about what needs to be addressed to close the testing gaps for hepatitis. So we know the European region has the most countries on track to eliminate hepatitis C by 2030, but progress for elimination in the region is definitely uneven, and many individuals and communities are still being left behind. So the fact that hepatitis is a viral infection that affects the liver and can lead to serious health consequences such as liver cirrhosis and liver cancer is still not widely known enough across populations. It's estimated that almost 30 million people worldwide, 30 million people across Europe are living with chronic hepatitis B and C, and across Europe, almost 170,000 will die from hepatitis-related liver cancer and cirrhosis each year. We know, unfortunately, many people with hepatitis are unaware that they have the virus, as they may not experience symptoms for years or decades, leading to chronic infection. So this is why testing is in fact so important, and so many of these initiatives are so important as well. The good news is that liver cancer and liver disease can be prevented if hepatitis is diagnosed early. And Europe is leading the way with connecting hepatitis elimination with cancer prevention and vaccination. But there's still a long way to go in closing the testing gap that exists across Europe. So working with the communities and civil society organisations and members that we work with, we identified several reasons for the testing gaps that exist. So in Europe, hepatitis B and C are concentrated amongst key populations, such as people who inject drugs, men who have sex with men, migrants, and people in prisons, and age cohorts who may have been exposed to contaminated blood products. There is a lack of awareness leading to a lack of demand for testing amongst these key populations, where hepatitis B and C are concentrated. Additionally, there are barriers to access to testing, such as the cost, geographic distance, and stigma across Europe. And there is a need to address HBV in migrant populations and those newly arrived and settled communities from high prevalence countries. Finally, there is a lack of investment and political will across some European countries to prioritise hepatitis testing and treatment programmes. So what can be done to close the testing gaps for hepatitis? The first step is to identify the communities and key populations affected and to increase their awareness and understanding of the disease. Many people with HCV are unaware that they have the virus and may not realise they need to be tested. This is particularly true for the key populations mentioned earlier, and those who are at higher risk of hepatitis, such as those who inject drugs, men who have sex with men, or those who have unprotected sex with multiple partners. So we need to do more to educate people about the risks of hepatitis and the importance of testing. We need more public education campaigns, targeted community outreach programs, better education for health professionals, and collaborations with healthcare providers and leaders. By raising awareness of hepatitis and the importance of testing, we can increase the demand for testing and reduce the stigma associated with the disease. In addressing other barriers to accessing testing, we need to invest in improving the access, which includes more community-based programs and HCV self-testing as well, especially in underserved areas and disproportionately affected communities. We need to work with governments and other stakeholders to ensure that testing is affordable and accessible. And this can be done through the implementation of policies and programs that reduce the cost of testing, increase access to testing sites, and reduce the stigma associated with the disease. An example of this could be mobile testing units, providing testing services to people who may not have as much access. When it comes to stigma and discrimination, this is a significant barrier for those living with hepatitis. Many people might be reluctant to get tested because they fear they will be stigmatized or discriminated against if they are found to have the virus. And again, this is particularly true for key populations. So we need to work to reduce stigma and discrimination for people with hepatitis, and this could include advocacy efforts, public education campaigns, and better training for healthcare professionals as well, who can provide non-judgmental and culturally sensitive care. Integration is really, really important. We need to work to integrate testing for hepatitis with other health services. For example, those who are being tested for HIV and other STIs as well, sexually transmitted infections, they should be tested for hepatitis at the same time. This can help to identify people who are at higher risk for hepatitis and ensure that they receive the care and treatment that they need. We need to increase investment and political will to prioritise hepatitis testing and treatment programmes. Again, this is through advocacy efforts, partnerships with governments and private sector organisations, and the development of sustainable financing mechanisms for testing and treatment programmes. All of these kind of methods and strategies to close the testing gaps for hepatitis align with the European Action Plan for ending AIDS, viral hepatitis, and sexually transmitted infections by 2030. So it's really important that we approach this with a multifaceted, collaborative approach. We put people living with viral hepatitis at the centre of the approach. It requires the involvement of healthcare providers, policymakers, advocates, and the general public as well. We need the right investments and political will to make significant progress. So just to conclude, hepatitis is still a serious health threat in Europe. The testing gaps do exist, and there are significant barriers as well to prevent and treat this disease. But as mentioned, by increasing awareness, addressing these access to barriers, and increasing investment and political will, we can close the gaps and still make significant progress to combat hepatitis by 2030. Thanks very much.
Thank you very much, Dahinder. Actually, hepatitis C is a different disease compared to HIV, although it can be eliminated and eradicated, can be cured. However, the people who are aware about the status is much higher compared to HIV. Okay, thank you very much. We'll continue with our next speaker, who is Nikos Dedris, and he represents the European AIDS Clinical, the ECDC, the European AIDS Treatment Group. and he's going to present about the current needs for closing the testing gaps for HIV in Europe and the role of the campaigns like the European testing.
Thank you, Dimitris. Hi to everyone. I would like to divide my speech today in two parts. One, it will be a few comments about the collection and analysis of the data that we have available. And the second is a series of surveys and research that the EATG conducted in the last few years on testing. So first of all, obviously, when we are speaking about testing, what interests us is diagnosis for both people living with hepatitis and people living with HIV. What is typically presented in annual national reports is the number of new infections that we had in the previous year. Second thing that it is presented is the modes of transmission. Then we typically evaluate the first of the 390s, the first 395s, in other words, the percent of people who are diagnosed, and therefore what is the percent of people remaining undiagnosed. And also the other critical data that we see is the percent of the late presentation, which currently is estimated in Europe to be 54%. Actually, the Minister of Greece said that this is a very poor performance for what we try to achieve in the HIV response. And we are all aware that this particular last piece of information is flawed. And last year, we had the adoption of the new late presentation consensus definition. And I hope, Anastasia, that the ECDC and local authorities will be in a position to collect the necessary data to distinguish between late presentation and actually recent infections with the utilization of indicators like having been tested in the last 12 months or using RITA sensitivity assays and so on. What I would like to say, nevertheless, from the side of the community and the people who advocate on the response to HIV is that we need very clear trends for each risk group. And therefore, this raises the issue of the need for reclassification of what is reported. Certainly the case of Russia is one of the worst examples where people, only 3% is attributed to men with sex with men transmission. So we need to make sure that we have these trends per risk group, as we can see them sometimes present. We see them at the European level, but it is critical to see them at the national level. The other thing is, after we correct the true percent of late presentation, to also have absolute numbers of estimated undiagnosed in a country, and also, again, analyzed per risk group, so that there is a consensus that we all know what are the differences between the different vulnerable groups in order to focus and focus the testing that we need to do. One overall comment is, as it was mentioned in the 2022 report referring to the 2021 data, is that there was an increase of new cases compared to 2020. Obviously, this is the result of the impact of COVID in its first year, which was a little bit remedied in its second year, but still 2021 appears to be 24% reduction compared to 2019. This is highly unlikely that we have had such a successful years where things have improved so far, which demonstrates that we have an issue with testing the right people at the right time. Now, this actually brings me to one of the first researches that EATG conducted, which was the rapid assessment for the impact of COVID to testing. And we know from its results and from the reports that the various countries have done that this has been not in good condition. But what we don't have, and this is the other thing that I wanted us to make sure that we report in a new way, is the number of tests which are being performed in the different countries. In the last report by ECDC, there are some countries who have reported, but certainly this is not universal. In Greece, we do not know these numbers, and certainly we do not know per risk groups as well. The other two surveys and researches that the EATG conducted, and I would like to make reference to, was about self-testing. So we conducted both a qualitative analysis and a quantitative. I will just mention a few of the collective results. First of all, in most of the region, we do not have self-testing kits approved in the various countries. And in some countries where there is these kits available, we do not have a clear regulatory framework, statutory, which would allow and in what setting this could be used. Actually, Anastasia, I think it's important that ECDC gives an opinion together with WHO of what is to happen with COVID-19 self-tests. I read in Greece that the doctors have been recommending that, well, the epidemic, the acute phase is gone. Therefore, these tests should not be made available at the pharmacy level. I would like to hear a dialogue about the pros and the cons of such a decision. And certainly in the case of HIV and hepatitis, this is not something that we would condone. The other thing that we know is that there are minimum age requirements. There are issues which have to do with industry-related incentives. So, in essence, in small markets, small countries, there is not an incentive. Therefore, this is to be identified by the state and provide the necessary opportunities in order this to be made available. The other thing, and with this I will close, is we still do not have a very clear regulation about community-run and community-based testing in many countries. So I think that we should do one more time a review of how this plays out across Europe and make very clear recommendations to countries to adopt legislation and regulation which would not only allow but promote and encourage community-based testing. Thank you very much.
Thank you very much. It was about a nice overview. We continue with the next presentation from the Positive Voice, which is a very active NGO in Greece. And they're going to present about the examples of Greek European testing week campaign activities that took place in Greece.
So hello everyone, my name is Georgios Keratsas, and today I'm representing Positive Voice and its centers, the checkpoint centers. Positive Voice is the Greek Association of People Living with HIV. And today I will introduce you to one of its most important successful projects, the checkpoint centers, and shortly present some of the activities that we have done for the European Testing Week. It's a great pleasure to be here today with all the involved members of the network in order to kick off the European Testing Week in the most proper way. Give me just 1 minute.
Can you hear? Esteban Martinez, can you hear us?
If it comes to the Pomino, I ask Ricardo from GAT, and then we can return.
Okay, we can continue with the next presentation on GAT from Carlos Fernandez about the local impact of European Testing Week and addressing missed opportunities for testing in Portugal. Ricardo, can you hear us?
Hello, everyone. Good morning from Portugal. Here is 2 hours early. I want to, of course, say that I appreciate a lot this invitation from Eurotest to be here. I want to say how proud I am that we have 3 members, including me, of the ETG as an ETG chair here, which means that the ETG is quite involved and engaged in solving these epidemics throughout Europe. And I want also to send a message to my friends of Positive Voice, which we do appreciate a lot, all their works and effort as a community organization of people living with HIV. I'll try now to share my my screen. Sorry, it was what I was trying to do. I think that you can see already the presentation. Can you see the slides or my presentation as well?
We can see with the presentation mode. Perhaps you can switch it to full.
I'm going to switch, but this is so many windows. Sorry, give me just a minute. It's here. Now it's okay?
Yes.
Yes.
Okay, thank you so much. So this is a quick slide with a table of the services and initiatives that we are promoting at GAT. Mostly at your left side, you can see a column with the target services. The target services are obviously targeted to some populations. Sorry, there's some Portuguese here, but you understand that each service is targeting some populations, because in Portugal, the epidemic is mostly concentrated. We as an organization decided to focus on targeting these populations that are most at risk or more vulnerable. So GAT was founded in 2001, sorry, and we only started to make screening service available in community context, especially to hard to reach populations in 2011. So 10 years later than we were founded. At that time, GAT started in 2011 a revolution in screening for HIV and other infections. We firstly opened the first rapid screening community center, the checkpoint, GAT checkpoint in Lisbon. And this was also a revolution because we allow testing for hard to reach populations that usually didn't have this opportunity. And from another side, we make HIV testing services more accessible and user-friendly, which was not the case at a national health system. So this paradigm, because at that time in 2011, we had only GAT checkpoint LCs, we also decided to scale up the testing with opening of new screening centers till now. And you can see that all of this on your left side are screening centers. This was, of course, because we needed to target other populations other than MSM, which was the case of checkpoint LCs. And we had the support of AHF Europe to do this, which was very important because it wasn't possible without them. Our impact strategy, it's mainly around HIV testing and STIs testing. And our strategy is mostly using testing as a cornerstone node for access to HIV prevention, meaning that we will not lose an opportunity to, of course, talk about prevention, condoms, loops, but also PrEP, but also test and treat. So in our services, we make sure that this is always an opportunity. Our services are tailored for HIV, early detection and timely linkage to care. We have everything integrated in our services, meaning that we offer not only testing for the main STI, so integrating sessions, as we have spoke already in this session. So we offer HIV, syphilis, hepatitis B, hepatitis C in every session, but we also offer vaccination, other STI testing. So we try to do everything in the same place so that people can get a sort of one-stop shop. Peers are enabled and involved, meaning that most or a big part of people that are testing, they are peers. So this means that people are more likely to feel at ease and to come because they know that they will find someone that belongs to their community, or that they will find someone that speaks their language, because this is also an issue sometimes. Linkage to care and healthcare navigation is provided because we understood that some populations had very difficult, they have a lot of difficulties to navigate the system to get to care. And this is an issue even for people, different people, that I have troubles sometimes to navigate the system. So I imagine someone that doesn't know the language or someone that are afraid so we offer a peer-to-peer escorting system where people get help to go to services, to navigate the system. And then we build strong partnerships with international organizations, but also with national organizations, community-based organizations that allow us also to work with the community. So in 2013, for the first time, we started to participate in the European Testing Week. At that time, in 2013, we were only using GAT centers, but in meanwhile, we create something that is the community network for testing in Portugal, which is a community of other organizations that can test for HIV. They are not all organizations working with HIV or hepatitis or other of these diseases. They are organizations that sometimes they are working with the populations that we are working as well. Meaning that as we couldn't reach to all the country, we invited organizations that were working with migrants or people using drugs, but they were not focused on HIV or hepatitis. And we invite them to test with us. And we gave them testings, training, and laboratorial supervision. And you can see that in 2015, it was the first time, and this is the left map, that all the network at that time participated. And so you could see that in 2015, we could cover a lot of the country already. But in 2023, you can see here, this is this springtime European Testing Week. You can see that we have much more organizations that are participating. So this is huge in Portugal, and it has a big impact as well. So we take advantage of European Testing Week mostly to intensify the screening of these infections. We could see in the COBATEST presentation that a lot of organizations take this advantage because there's this peak of testings in this week. So we do it indoor, as you can see in the photos. We do it in our vans. We do it in tents, pop-up tents. We give information, and we take also the opportunity to communicate about this initiative and the importance of early screening and treatment for individual health and public health in the main television channels, newspapers, and social networks, so that there's also a side of awareness and advocacy that needs to be covered, and we try to do it at the same time. So, and almost finishing, just talk a little bit about the impact in terms of numbers. It's a very simple slide. From the last European Testing Week in November 2022, we had, as you saw, a lot of organizations. So we have 22 community-based organizations, 56 screening sites in November 2022. You can see that in a week, we did 3,000 integrating testing sessions. As I told you, we offer always the 4 infections. And we had these cases of positive, 24 for HIV, for instance. And you can see that in 1 week, we discover 2.6% of all the positive cases that usually we discover in a year. I compare the data from 2021, which is the data that we have available, but this is just to have an idea. And you can see as well that doing 3,000 tests in 1 week was also 7% of the total goal in a year for the country. So I think that this week has really an impact, not only in terms of the awareness, but as well in terms of the number of people that we are diagnosing. You can see that there's also interesting numbers for HBV and HCV. Unfortunately, we don't have such good data as Anastasia know from Portugal in this case. So we can compare, but we think that this has a huge impact in populations. So for us, this is an initiative that we always try to promote, be it in spring, be it in the November, the autumn one. So thank you so much. Thank you for as well to the GAT team that is always very, very engaged in these opportunities. And thank you also for your attention. Thank you to our partners, AHF Europe and Coalition Plus. Without them and all our partners, our work will be much more difficult. And please take this opportunity to follow us on social media and stay up to date with our activities. Thank you so much.
Thank you very much, Ricardo. Really very interesting results. Congratulations about this effort that you have done so far about the implementation of European Testing Week in Portugal. So we'll continue with the representatives of Positive Voice that couldn't present a few minutes ago. And the presentation is examples of Greek European Testing Week campaign in this list.
Hello, everyone again. As I mentioned earlier, I represent Positive Voice, the Greek Association of People Living with HIV, which was founded in 2009. And today I will shortly introduce one of its most successful projects, the Checkpoint Sexual Health and Prevention Centers, the REF Checkpoint Centers located in Athens. So, in order to start, a few words about who we are. We are the only community-based HIV testing and prevention center in Greece, with a range of services for HIV vulnerable groups, such as members of safe defense, members of the LGBTQI community, people who use drugs, sex workers, refugees, migrants, as well as the general population. We have 2 centers, one located in Athens and one located in Thessaloniki, but we also have mobile units in order to provide street activities. The Athens Checkpoint Center was established in 2012, which means that we have now completed 10 years of functioning, and the Thessaloniki Checkpoint Center was founded in 2014. I will shortly introduce what our services are. So we provide testing for HIV, hepatitis B, hepatitis C, and syphilis. And the tests we provide are always rapid, confidential, and free of charge for all the beneficiaries and presenters. We provide counseling on sexual health issues. We distribute free condoms and informative leaflets, and that goes to the people who visit our centers, but also through the street activities. Through the street activities, we provide testing for vulnerable groups and informative material and condoms. We also have the partner education system, which is a system that lets someone who was had a reactive test at the checkpoint centers inform their partners anonymously that they had an infection so that they can also get tested. We provide linkage to care, which means that we accompany someone who was diagnosed at our centers to the HIV clinic and we sell everything. We make referrals when it's needed, and we also provide a new service which is called Tech Support, and it's some sort of counseling for people who engage in games activities. I will also introduce our new center, which is called Refugee Point. Refugee Point is located in Athens, and it provides services for refugees, migrants, and asylum seekers. More or less, it has the same services as Athens Point, but the difference is that all the services are catered to the specific group, and the services provided are in the beneficiary's native language, which means that the counselors and therapists who work there speak English, French, Spanish, Portuguese, Arabic, Farsi, and Dari. During the 10 years of the Checkpoint Center, we have provided more than 100,000 tests for HIV, 23,000 tests for hepatitis B, 26,000 tests for hepatitis C, 5,000 tests for syphilis, more than 1,500 HIV diagnoses. On a national level, this means that through the last year, we have made approximately 1/3 of the diagnoses in Greece. More than 70% of the people diagnosed with the centers have been successfully linked to the national health system. And as you can understand, taking into consideration the circumstances and the situation in Greece, the checkpoint centers have played a key role in the promotion of sexual health and prevention, having fostered a culture of regular screening and ongoing information. They have been mentioned as best practices by the World Health Organization and the ECDC, and they have been visited by the current Prime Minister, the former Prime Minister, the President of the Republic, etc. Now, in order to present some of the campaign activities that we have done through the years, I will use the example of what we did in the Autumn European Testing Week 2022, which, in my opinion, is a very complete campaign. So, as usually, we expanded the operating schedule of the checkpoints, which means that the centers in Athens and Thessaloniki remained open every day of the European Testing Week from 12 to 8, except for Sunday. A difference is that we welcomed beneficiaries without the requirement of booked appointments. We organized plenty of outreach activities through the Streetwork project. These activities are meant to target different vulnerable populations, such as men who have sexual men, people with use drugs, and refugees and migrants. This is always a collaboration with other organizations like Okana or GAT, and with the help of the municipalities in Athens and Thessaloniki. We kind of used the idea of some testing ambassadors, which means that we invited Greek artists, journalists, and influencers to visit our centers, get tested for HIV, and share the word on the social media platforms. This is more or less an initiative to raise awareness among the general population and not so much specific groups. And it led to some recruitment. We also published a press release about the European Testing Week to a long list of journalists, which was shared by a number of online media. We established a collaboration with LGBTQI radio channel, which is called Pride Radio. So we had daily interviews, and they shared all of our activities on air. And we took over the European Testing Week Instagram account for 1 day, and in order to present our efforts. And I will use this as a conclusion. This is more or less to kind of show how much of an impact the European Testing Week can have. Throughout the European Testing Week in November, which means from 21 of November to 28, we made more than 600 HIV tests, 687. And compared to an average weekly number of 250 tests, this means 300% increase. So this is to show that how beneficiary the participation in the campaign can be. This was it. Thank you very much.
Thank you very much. Very important, very interesting data about the activities of voice. Now it's our pleasure to introduce Esteban Martinez, who is the president of DIACS, and he is going to present about the importance of early testing from a clinical perspective.
Oh, thank you. And first of all, apologies. I had appointments at the clinic, and my hospital suffered a cyber attack, and I was unable to run Zoom from there. So this is the reason of my delay. I'm very happy to share with you my presentation on the importance of early testing. And probably the importance of early testing comes from the opposite view of the bad consequences of late presentation. So I will outline the points regarding the individual, regarding others, and also regarding the health system. And for the individual, the most important thing of being diagnosed early is that if you are diagnosed late, you will have an increase in mortality. And this is whichever the age you may have, whichever the gender, whichever the characteristics that you may have. Being diagnosed late is a reason for dying early. And this is data from the UK, and you can clearly see why the mortality is higher in those diagnosed late. And also, being diagnosed late means that the CD4 cell count may be decreasing progressively. And this is something that it's not going to give any benefit, but additional prejudice, because the lower the CD4 cell counts, the higher the risk of mortality. And this is particularly true below 350. You know, probably those who are older know that antiretroviral therapy was not always prescribed from the beginning, and there was a latency in the prescription due to the toxicity and due to the lack of evidence to prescribe early. But the START study and other studies clearly showed that the prescribing the medication, antiretroviral therapy early, was able to not only decrease the risk of death, but also decrease the risk of age events and non-age related comorbidities. And the latter was something that was surprising because it was not expected. Also, despite the benefits of antiretroviral therapy, if you have a lower CD4 cell count, irrespective of the combination that you may be using, the possibilities of success with antiretroviral therapy are much lower. So this is an additional point to start earlier. And this graph exemplifies very clearly that the lower you may begin with receiving antiretroviral therapy, you may have a relative increase in CD4 cell counts, that it is apparent whichever the level at the beginning, but the absolute level that you may acquire has a threshold, and this is much lower when the initial CD4 cell counts were low. So not only mortality, but also comorbidities, the lower the CD4 cell count, the higher the risk, not only for age, but also for non-age comorbidities. And now that the potential for survival, for life expectancy in people living with HIV has increased over time, approaching to that of the general population, and this is good news. The important thing is that the life expectancy free of comorbidities has not increased too much, and this is inversely related to the level of CD4 cell count. So the better the CD4 cell counts, the earlier that HIV is diagnosed and therapy is started, the best. For others, the possibilities, the risk of transmission. There are some potential routes of transmission, such as transfusions or vertical transmissions, in which the requirement or the recommendation of an HIV test is very apparent. But for sexual exposure, the risk it is, and certainly there is a much higher risk with some kind of sexual exposures than with others. And this is important because each of them adds on to the previous risks. So not only the times you may be exposed, but the viral load may also increase the risk of acquiring HIV. The higher the viral load, which usually is higher as the CD4 cell decreases, and this is with longer HIV exposure, the higher the risk of acquiring HIV. And one could think that, well, as soon as you get the diagnosis, you can have a very immediate or early therapy. And this is good, obviously, but the time from seroconversion to the diagnosis of HIV or the administration of antiretroviral therapy, as inferred from this recent paper in New York, is between 3 and 4 years. So you can imagine that the time at risk being years is very important for the transmission of HIV. So new infections are coming mainly for those people who are HIV infected but not diagnosed, or even HIV diagnosed but not retained in medical care. These are data from the US. We have not similar data from the European Union or Europe as a region, but we assume that this may be also the case. The good thing is that when any person with HIV starts antiretroviral therapy, the potential for transmission of HIV through sex is 0. And this is outstanding because it is very strange to say in medicine that the risk is 0, and this has changed the life of many, of all persons with HIV in an incredible way. For the health system, the issue is that these are data from the Netherlands, very recent, and being diagnosed earlier on the left-hand side compared with those diagnosed late on the right-hand side. In the first 5 years, as expected from this economic analysis, is much more expensive for those presenting later. And this is not only regarding antiretroviral therapy, which the difference is small, but in other non-antiretroviral costs. And taking into consideration that this is not for an individual person, but for the conjunct of the population, you can see as unfortunately late presentation is so common, between 40 and 50% in different European countries. This can translate in a huge amount of excess of cost. So that's my presentation. Remember, implications for the individual. This is the most important and immediate. For others with the transmission of HIV, and for the health system. Thank you for your attention.
Thank you. Thank you very much, Esteban, about this very interesting data and about the effect of late presentation with regard to the clinical importance. Since we have finalized with all the presentations, we'd like to thank you for that and to open the Q&A session. So if there are any questions about any of the presentations that I have made, please raise your hand. I'm asking for those who attend online, if there are any questions or comments, please raise your hand in order to moderate the discussion.
Can I start with a question? Anastasia, could I ask you with regards to some of the issues that I raised in my speech regarding the new, let's say, version of the late presentation and how optimists are we in how it will play out? And also about the numbers of testing and have you undertaken any initiative from the ECDC side in order to have more numbers?
Yeah, thanks, Nikos. So for the new definition of late presentation or late diagnosis, we actually implemented this already in the last report, which we published in November. And that meant to exclude these people who are diagnosed very early. So there's this initial dip in the CD4 count. And sometimes we have, because we just take CD4 less than 350 as a proxy for late diagnosis, there's been worry that we're then misclassifying some acute cases as late. So we do have a variable in surveillance if countries report it around acute infection, and they can report, did this person have a recent negative test, some different laboratory markers that are associated with acute infection. So where countries reported it, we already are excluding those cases. The problem is the reporting. So we need to work with countries, and we will discuss this at our upcoming network meeting. How can we improve the reporting around that variable so that we have better reporting? So that is already implemented, and we're working on that. The testing numbers, we have worked on this for more than a decade, and it is honestly not something where we're seeing a lot of movement at surveillance level to really get, concrete numbers of testing. There are different reasons for this in different countries. In many, it's due to just not having agreed information flows between laboratories and surveillance, like public health. But some countries do have very good testing numbers. And so maybe what we need to do is, with a subset of countries that do have the kind of legal frameworks and organizational frameworks already in place, at least to do a deeper dive in those countries to look at changing over time. And then one thing we did do, even though we don't know the testing numbers, we did add a variable this past year, and I'll analyze this now going forward, around the site that the person was first tested. And this is quite interesting, I think, for many of you. Was it in a community site? Was it an infectious disease clinic? Was it a harm reduction center? So these are only for positive new diagnoses, so we don't know overall testing numbers, but at least it provides some indication that I think is quite interesting and helpful to look at. So some reflections on that.
Can I make a quick follow-up question?
Yeah.
So in how many countries have you already implemented the new definition? And obviously didn't make any dent in the late presentation. So if you were to analyze just those countries, the previous year where this new definition was implemented, what was the difference?
The difference at European level was very small. It was like 1-2%. And so when we exclude those cases from the denominator, it doesn't make a marked difference at all, really. And then we've also got COVID impacting things, where we know that we had a lot fewer people diagnosed in 2020. So there is probably an impact on increasing late diagnosis for that reason. So it's all quite muddy and hazy. But like I said, not report this. And so I would say it's probably about 15, 16 countries in the EU, about half that report, or some report, but they have low completeness. And so what we see now, it's not made a very big difference in terms of really an impact. I think it's safe to say late diagnosis is still a big issue. We're not misclassifying tons of acute cases, unfortunately. I wish that were the case, but it is still a big issue. Too many people come and are diagnosed with HIV because they have AIDS-associated conditions, and they're coming very, very late to Esteban and other clinicians, and only diagnosed at that point.
Okay, thank you very much, Anastasia. I would like to raise one issue with regard to late presentation. As far as we show from your data, but this is also our experience in Greece, that late presentation is much more frequent among those who are older. And it seems that it's increasing with age, and also with among those who present themselves as heterosexuals. Although that probably there are any some who deny their status, their sexual orientation, and although there is a lot of progress and a lot of experience from the community testing with people who feel more confident about their status, about their sexual orientation, I think that we should discuss and find different ways to approach people who still feel stigma regarding their age, regarding their socioeconomic status, regarding their profession, regarding their life, and they don't approach very easily community testing services which are more MSM oriented. I don't know who would like to comment on that. Yes. I would like to invite also to give information from Harris, who is the president of the Organization Against Drugs. Please.
Good morning to all. Good morning, Dimitris. Good morning, Spiros, Nikos. And I'm very happy to hear all the incidents on the testing and care on HIV and HCV. As you all know, organize the National Organization for Drug Treatment and Harm Reduction. And lately, we've done many things in order to try to reduce all the risks from the use, because the PWID are the most let's say, high-risk population that we have in our country. First of all, we have the DCR here, the drug consumption room, where we can see that we have more than 11,000 visits for the first year, and around 1,000 people going there. And the harm reduction actions that we have done here have been intensified by the operation of 4 mobile units in several cities in Greece. And through our, let's say, last year's operation, we have distributed more than 616,000 syringes. And we will reach probably in this year, in 2023, we will reach almost the 1 million syringes distribution, which is a long far away from the average, let's say, distribution that we had in the past. The thing is that we have a big population in our programs and in our premises. With HCV and of course with HIV. So we've done these 2 programs that if you don't know, TTOS and Hippocrates. TTOS is for HCV, who will examine all the people who are in programs, in OST programs, and then in harm reduction services. Almost they have been tested. I think it's around 1,500 people tested, and we will have around 3,000 people tested all over Greece. So it's, I think, one of the biggest, let's say, nationwide program for the HCV elimination. As well as we have also this program for HIV, the algorithm that we will have with the system that Hippocrates, it's so-called the program, for our users as well. We have detected a small or a big, we don't know yet. We are trying to do a cooperation with AOD, and we are in the middle of this thing. We have detected an outbreak of HIV in Thessaloniki, which is very crucial, and we want to have this tested. Professor Paraskevis and the Vice President Sapounas, we have discussed on this issue, and we are planning to do some actions together, because this is too crucial for this population and the population of the general population of Thessaloniki. We think that this is much more than the outbreak of Athens of 2012. So we must go on that and have a very short and very immediate actions on this situation. I hope that these kind of discussions and meetings to be done very often, because we always need a feedback from you and from us to discuss several issues that concern us. Thank you very much, and we are very happy to have you here.
Thank you very much, Dr. Harris, about all the actions and the activities that have been performed so far, focusing on targeting people who inject drugs, really important services, not only about the harm reduction, but also for making for the first time, for establishing the room for safe injecting practices. Very important. Gigas Magiotinis has asked, he wanted to make a comment. He's associate professor at the University of Athens, and he's also the head of the National Antivirus Reference.
Good morning, and I think there were very interesting presentations here and very important messages that passed through. I would like to share a bit of my experience, like 10 years ago, that we were analyzing Hep C and HIV sequences to see where transmission is coming from. I remember one of the examples that we were saying is that when we want to design a program for testing that would prevent transmission, we need to identify the source of the transmission. So I remember doing a sketch with a boat that has two holes and water is coming in, and then someone is getting a bucket and trying to throw out the water. But when you're trying to throw the water, you're not stopping the boat getting water. And what I'm saying is, you might get, if you test late, obviously you don't prevent any transmission, you prevent morbidity, mortality. So it is very important to identify where transmission is coming from. And obviously this is coming from, for example, with Hep C during needle sharing. So it has to do with IVDU. So, and we had data showing that this is happening within the first 2 years of injecting drug use. And we had some similar data about HIV in Russia that is happening much earlier, like within the 6 months. Within the first 6 months that someone has been infected, most of the transmissions coming from that person happened within these 6 months. So I'm not sure we, like all the testing programs have identified this issue, which means that we have to find the barriers reaching these people. And the barriers are why I think we know them very well. I'm not sure we're targeting them. So one thing is like, are we testing IVDUs while they're like in the most intense drug use that they're doing? Are we reaching them? And also the same with HIV, are we reaching up the high-risk people and providing a very easy testing platform for them? And the other thing that I have heard like quite recently is I'm not sure, is anonymity a barrier? And do we provide enough anonymity to these persons within the as we should? And do we, I mean, my feeling is that anonymity is a big issue and we have not done enough. Yeah, these are like my thoughts, and thank you very much.
Thanks a lot, Gikas. Next was from Ben. Would you like to make a comment?
Certainly. Demetrius, I want to get back to your question about the data on late presenters, that there's such a high number of late presenters and what can be done about that. I felt Tejinder did a very good job of outlining the problem in hepatitis. And I felt like, Tejinder, you did a great job. It's quite similar to the situation for HIV. I also felt like the demonstration of the positive voice work of identifying specific populations, refugees, people doing chemsex, gets back to what you were talking about in terms of identifying what the sources are. And not that the refugees are the source, the refugees are in a situation where they're quite at risk. One thing that wasn't mentioned that I think is interesting is a new testing system that's going on in the UK, which is happening in the A&E and in emergency rooms. It was trialed in very high prevalence for us, where there were a high number of people with HIV or hepatitis, and now it's been rolled out so that it's basically opt-out testing. If you're going to have blood drawn in the A&E, you are going to get an HIV test, a test for hepatitis and STIs, unless you say you don't want it. And it's still in the early days, but in the first 10 months, they identified 900 infections, and surprisingly, most of them were in hepatitis. But I think that really speaks to what you're talking about, is that a lot of the people who are HIV positive or Hep C positive or have STIs do not intersect with the services that are currently provided, and it's really essential to generalize those services and to make them more sensitive. It also does a very good job at reducing stigma. It just normalizes testing. And I can't tell you the number of opt-outs, but I think the level was quite low. So it's an interesting opportunity.
Okay, thank you very much. We have also the representative of the world, and you want to make comments?
Soteris Kousoglu, I represent Doctors the World, the medical coordinator. I'm very happy to be here. What we heard today was very interesting and very useful. Just I wanted to say that how important it is to emphasize that these people have to be tested for all the sexual transmitted disease, not only for HIV. In our activities, both in our polyclinics and in external activities, we test these people for syphilis, for hepatitis C, B, and HIV. We are trying to convince these people that is also very important to know if they have something else, not only HIV. Thank you.
Yeah. I think this has been demonstrated also by data that combined testing was beneficial and also gave additional results and benefit with regard to hepatitis and STIs. Magdalena.
Hello. Yeah, I would like to add something for the discussion. Thank you for this very interesting meeting and very interesting presentation. I'm from Foundation for Social Education. It's NGO working in Warsaw in Poland. And from the European perspective, Poland has right now a huge issue with war migrants. And it's especially important what you mentioned about late presenters, because Poland and Ukraine has the highest number of late presenters in Europe. And it's more than half of new cases are late presenters in Poland, and similar situation is also in Ukraine. So right now we have also a huge barriers of testing, because only 10% of adult people in Poland had ever tested in their life before the war. And right now we have new impact of epidemic, especially with women living with HIV, because in Ukraine, 47% are women living with HIV. In Poland, it's less than 30%. So this is also something that we have to keep in mind, that Europe will have a new epidemic of women. It wasn't so obvious in the last few years. And from my perspective in Poland, it's still an issue how to invite Ukrainian migrants for testing, because they are really afraid to disclosure their status. They also do not know the system that is working in Poland, that if they are afraid if they will be HIV or hepatitis C positive, what will happen with them in Poland. So this is something that we have to keep in mind, especially when Poland had before the war, the quite low level of testing. And also it's not like in other countries. Testing in Poland, it's not so easy because we don't have self-testing program, a national self-testing. It's only organized by NGOs, and my foundation and other organizations try to find any funding for this. And we know that this is probably self-testing for Ukrainian migrants can be good option, but for this moment, we don't have any funding for HIV in Poland for war migrants. So it's something new for us. but we are extremely in the situation that we know that a lot of those people will stay with us in Poland. So we have to, first of all, do the prevention. From other side, give it an option for testing. The easiest way is with treatment, because Poland have access for treatment for everybody. But this is also about knowledge and increasing testing, especially with late presenters. Thanks.
Thank you very much, Magdalena, about this very important comment. Actually, Ricardo, please allow me, Anastasia, probably she wants to comment on that. And I would like also to make a brief comment to Anastasia. If it's possible, without stigmatizing Ukraine, to take this into account, that we may have some heterosexual women late diagnosed since they are refugees from Ukraine. It's one of the countries with the highest prevalence of HIV that causes an increase, but it's not true, of late presenters among heterosexual women who are refugees from Ukraine and living in European countries.
Sorry, Dimitris, is it me or Ricardo first?
Is your comment related to previous comment?
Yeah, it's a bit related to what Magda just said, so it's okay.
You to allow Anastasia.
Okay, I'll go. Thanks a lot. I think it's also really, really important that we think about testing as a possible engage people in care who are already diagnosed, and we see this as an increasing issue. More and more of the cases that we find reported to surveillance are people that are not being diagnosed for the first time, but they're moving. And this is an issue, of course, for people from Ukraine who are in many different European countries, but also for other migrants. And so sometimes when moving, HIV is not the top priority, but there are other reasons that people move, and HIV may not be the first thing that people then attend to, but may only after they settle then get linked in. And so that's a really, really important thing that we need to think about, is this re-engagement piece, and that European Testing Week is a possibility for that, and community sites across Europe throughout the year are a possibility for that. So that it's a way to kind of relink them in. And then I think previously there was a comment on how can we reach these heterosexual populations or others who are diagnosed late. And I mean, that can of course be the role of community centers, but I think that also reaching key populations, that's done really, really well. And I think, don't stop doing that and try to broaden to reach everyone if that's not going to work in your setting, but keep doing what you're doing well. And this is the job also of public health, to look at which populations are we missing and how can we improve that. And there's a lot of routine, antenatal screening. There are possibilities for the really good example that was mentioned from the UK on the accident and emergency department screening, just routine screening of anyone who is giving blood for any reason. It's cheaper and cheaper to add on an HIV or hepatitis test. Do it. Recent example from the US, they're doing birth cohort testing for hepatitis C, but also now for hepatitis B. So countries can look at, kind of more routine testing to engage populations that maybe don't see themselves as a risk group or don't tend to come in contact with risk services. And this also, I think, applies to the populations from Ukraine. But it is extremely important to do extra work to ensure that people, don't feel stigmatized and know that they will get treatment. Otherwise, why would they want to know their status if that's not insured, and if it's going to jeopardize their migration status or other health issues. Yeah. Thanks. Over.
Thank you so much. I wanted to just do a brief comment about what Ben was saying, which was a little bit thinking out of the box to reach to people that are late presenting. And I think that one of the strategies that we've been really bad to implement is self-testing. I think this is a huge missed opportunity, and there's a lot of regulations in countries that don't allow us to buy or distribute self-tests which I think that this is something that we need to improve. And we are missing. Someone was talking about anonymity, and I think that this is a way also to offer that to people, you know, so they can do it in themselves, and also and as someone is saying, it has been done in COVID testing. So this is such a mental obstacle, you know. It's not even because people think, oh, but if someone discovers that has HIV alone in their homes, it's a big drama. And we cannot think like this, because it's better to be a drama than losing their lives or infecting other people. So this is something that we have to work, not only in this strategy, but other strategies, like Ben was mentioning, in, you know, ERs doing tests. We did it in Portugal. It wasn't a great experience, but we have some data about that. Another thing is that what Anastasia was saying, that we've been doing a good job with some more vulnerable population. But what is happening now, and I was just looking to a graphic that I have from GAT since 2010, we started to test less and having a lot of high rate of positives, and now we increase all over the years. We increase a lot testing. And now we are doing more than the triple of testing, but we are having a decreased rate of reactives, which means that we have tested a lot more to have the same or even less reactive cases. It's not understood correctly by donors, by states, that we need to do this effort to test more, to keep searching and finding people that are still infected. So I think this is something that we need also to talk about it, because some people might think that we don't need to test anymore because this is such a small number of new infections that we are comparing with the beginning. So we are, in some countries, we have reached the 90,000 people, 90% of people that knows about their HIV diagnosis. But in Portugal, they say that we reach 95, but we still need to find those 5% that we didn't reach to them, although we did a lot of testing and we use a lot of strategies. So we need to find new strategies like self-testing to reach the other 5, 10, 50% that we are missing in our countries. So this was my comment.
Yeah.
And it's Esteban and Ben Collins.
Yeah, well, I couldn't agree more with that. I think if we take a look at who lay presenters are, usually heterosexual, older, maybe migrants. So the characteristics that may be behind are either the conception that you are not part of the risk, so this cannot happen to me, and this is what I have witnessed, and also the lack of availability to the health care system. For instance, migrants sometimes cannot have the papers to access the public health system, and despite they may have them, the language barriers, the cultural barriers, the other inequalities may hamper them for getting this healthcare access. So I think, although it is approved and the countries may be behaving differently, I think an integrated care for migrants, just providing in a proactive way healthcare, and within this package of healthcare, the possibility of testing for HIV and other transmittable diseases, infections, I think it makes sense. It's already approved in many European countries, but sometimes because of economic problems or because of political issues, this is not applied. And for the older and heterosexual, those people that may not be considered themselves that they are at risk, I think one step would be the access to healthcare system. So emergency visits, visits to the primary care physician. These are possibilities to take into consideration and to make doctors who are not devoted to HIV to be confident and to be aware of this possibility, and also the possibility of self-test. I think this should be further promoted, because although you may have access to a clinical healthcare system, sometimes I have seen persons older with pneumonia, for instance, and you give the advice to perform an HIV test, and because of the social links or because of the family, they firsthand deny, well, this is not with me, I think I am not at risk, and they deny the possibility to do it. So a kind of performing some self-testing would preserve confidentiality and would allow the possibility to get this diagnosis done.
Very much, Stefan. Then Ben Collins.
First, thanks, Esteban. You put in a comment about the kind of practices that we initiated in COVID, and I think it's very important for us to remember that. The kind of work that we did in COVID is exactly the kind of work that we're needing today for HIV, hepatitis, STIs, the idea of integration. I think this does raise the important issue of diagnostic companies and diagnostic tests. Because we're looking for innovation there, and I'm happy to say that EATG and Eurotest have been collaborating on the HepHIV conference in autumn in Madrid, and we're hoping to have a discussion with diagnostic companies about innovation, be actually dealing more, addressing with those populations that we're having difficulty testing.
Okay, thank you very much. Actually, a housekeeping message that the platform is going to need to be interrupted in 5 minutes. So if we have any comments before we make the final conclusions. We were very glad that we hosted this event. I think there were important messages and important discussions. Very important to remember that the self-testing should be used more and more in the future. Also, all the testing services should continue. As we have seen, the results are very important. They are very beneficial to the community. All services and harm reduction services for special populations like people injecting drugs are also very important, should continue. There is a lot of work to do for populations who are not easy to approach, like migrants, and they need not only testing services, but we need also to improve our ability to provide treatment and counseling for them, and to approach these populations who not have access to provision of care, and also for people who still feel stigmatized and cannot easily approach services who focus on MSM. So although that there's a lot of progress, and we need to make this clear, there's a huge progress on testing services and on diagnosing people with HIV, hepatitis, and STIs. We still have many things to do, and I think these initiatives, like the European testing, is important to keep us on this track in order to be better and to improve even more testing and the cascade of care. Thank you very much for your participation. I'm looking forward to meeting you on different occasions.
Bye-bye. Thank you.
Bye-bye.
Thank you.
Thank you.
Θανάση, είσαι μέσα? Ναι, ήταν. Έφυγε. Ναι. Πάμε και εμείς.